Welcome to our educational video on bladder pheochromocytoma, a rare and often overlooked condition affecting the urinary system. In this video, we'll delve into the details of this disease, covering its causes, symptoms, diagnosis, and treatment options. Join us as we explore the complexities of bladder pheochromocytoma and shed light on this uncommon but significant medical condition. Bladder pheochromocytoma, at its core, stems from the proliferation of chromaffin cells within the bladder wall. These cells, normally found in the adrenal glands, produce and release catecholamines like epinephrine and norepinephrine, also known as adrenaline and noradrenaline. While the precise trigger for this aberrant growth in the bladder isn't always clear, several factors may contribute. Genetic predispositions play a role in some cases, as mutations in genes associated with hereditary pheochromocytomas can increase the risk. Chronic bladder irritation or inflammation might also be implicated, though the exact mechanism remains under investigation. In essence, the etiology involves a complex interplay of genetic susceptibility and, potentially, environmental factors leading to the development of these catecholamine-secreting tumors within the bladder. The pathophysiology of bladder pheochromocytoma revolves around the excessive and unregulated release of catecholamines from the tumor cells into the bloodstream. These hormones exert a powerful effect on the body, triggering a cascade of physiological responses. When catecholamines surge, they bind to receptors on various tissues and organs, leading to increased heart rate, elevated blood pressure, and vasoconstriction, which is the narrowing of blood vessels. In the bladder itself, catecholamines can stimulate bladder's smooth muscle, potentially causing spasms and contributing to urinary symptoms. The intermittent nature of catecholamine release leads to paroxysmal symptoms, meaning they occur in sudden, unpredictable episodes. Over time, chronic exposure to elevated catecholamines can damage the cardiovascular system and other organs if left untreated. Therefore, the key mechanism involves the uncontrolled secretion of these potent hormones and their subsequent effects on multiple systems throughout the body. Bladder pheochromocytoma is an extremely rare disease. Precise epidemiological data is limited due to its infrequency. It represents a very small percentage of all pheochromocytomas, the vast majority of which are located in the adrenal glands. While it can occur at any age, it is most commonly diagnosed in middle-aged adults. There does not appear to be a significant difference in prevalence between men and women. Given its rarity, population-based studies are challenging, making it difficult to determine definitive risk factors beyond the genetic predispositions discussed earlier. The condition often goes undetected for a prolonged period, further complicating epidemiological assessment. Therefore, recognizing the signs and symptoms and maintaining a high index of suspicion in appropriate clinical settings are crucial for timely diagnosis and management. The signs and symptoms of bladder pheochromocytoma can be dramatic and, at times, frightening. The hallmark of the condition is paroxysmal hypertension, meaning episodes of extremely high blood pressure that come on suddenly. These hypertensive crises can be accompanied by severe headaches, profuse sweating, and palpitations, which are rapid or irregular heartbeats. Uniquely associated with bladder pheochromocytoma are symptoms that occur during or after urination, such as a sudden rise in blood pressure, headache, or palpitations. Other possible symptoms include anxiety, tremors, and nausea. The intermittent and unpredictable nature of these episodes can make diagnosis challenging, as patients may be asymptomatic between attacks. Importantly, not all patients will experience all of these symptoms, and the severity can vary significantly from person to person. Prompt medical evaluation is essential for anyone experiencing these symptoms, especially if they are linked to urination. Diagnosing bladder pheochromocytoma requires a multifaceted approach. The initial step often involves biochemical testing to detect elevated levels of catecholamines and their metabolites in the urine and blood. Specifically, 24-hour urine collections are typically analyzed for metanephrines and catecholamines. Plasma metanephrines are also commonly measured. If these tests are positive, imaging studies are performed to localize the tumor. Computed tomography or CT scans and magnetic resonance imaging, or MRI, are the primary imaging modalities used to visualize the bladder and surrounding structures. A specialized scan called an I-123-MIBG scan, which stands for methiodobenzoylguanidine, may also be employed. MEN-IBG is a compound that is taken up by chromaffin cells, allowing for more specific localization of the tumor. Finally, cystoscopy, a procedure where a small camera is inserted into the bladder, can be used to directly visualize the tumor and obtain a biopsy for confirmation. A biopsy is crucial to confirm the diagnosis and rule out other potential conditions. The combination of biochemical testing, imaging, and histological confirmation is essential for accurate diagnosis. Bladder pheochromocytomas are generally classified based on their size, location within the bladder wall, and whether they are benign or malignant. While most bladder pheochromocytomas are benign, meaning non-cancerous, a small percentage can be malignant, indicating they are cancerous and have the potential to spread to other parts of the body. The malignant potential is determined through microscopic examination of the tumor cells following a biopsy. The classification also considers whether the tumor is solitary or multiple, meaning if there is one tumor or several. Staging systems, which are commonly used for other types of cancer, are less frequently applied to bladder pheochromocytomas due to their rarity. However, when malignancy is suspected, staging might be considered to assess the extent of the disease and guide treatment decisions. This classification, though relatively simple, helps guide treatment strategies and predict prognosis. The treatment and management of bladder pheochromocytoma primarily involves surgical removal of the tumor. This is usually performed via a partial cystectomy, which is the removal of a portion of the bladder wall containing the tumor. In some cases, a radical cystectomy, involving the removal of the entire bladder, may be necessary, particularly if the tumor is large, deeply invasive, or malignant. Prior to surgery, patients are typically treated with alpha blockers to control blood pressure and prevent hypertensive crises during the procedure. These medications block the effects of catecholamines on blood vessels, helping to maintain stable blood pressure. In cases of malignant bladder pheochromocytoma, additional therapies such as chemotherapy or radiation therapy may be considered after surgery to reduce the risk of recurrence. Regular follow-up with biochemical monitoring and imaging is essential to detect any potential recurrence. A multidisciplinary approach involving surgeons, endocrinologists, and oncologists is crucial for optimal management. While there is no definitive way to completely prevent bladder pheochromocytoma, certain measures can be taken to reduce the risk, especially in individuals with a family history of pheochromocytomas or related genetic syndromes. Genetic screening and counseling are recommended for individuals with a known family history to assess their risk and potentially identify genetic mutations that increase susceptibility. Early detection and management of any underlying bladder conditions, such as chronic inflammation or irritation, may also be beneficial. Maintaining a healthy lifestyle, including a balanced diet and regular exercise, can promote overall health and potentially reduce the risk of various tumors. However, it is important to emphasize that bladder pheochromocytoma is a rare and often unpredictable condition, and even with preventative measures, it may still occur. The prognosis for bladder pheochromocytoma is generally good, especially when the tumor is benign and completely removed surgically. With successful surgery, most patients experience resolution of their symptoms and normalization of catecholamine levels. However, long-term follow-up is crucial to monitor for any signs of recurrence. The prognosis for malignant bladder pheochromocytoma is less favorable, as the cancer can spread to other parts of the body. In these cases, the prognosis depends on the stage of the cancer at diagnosis and the effectiveness of adjuvant therapies such as chemotherapy and radiation therapy. Recent research has focused on identifying novel therapeutic targets for malignant pheochromocytomas, including targeted therapies that specifically attack cancer cells while sparing healthy tissue. Advances in genetic testing are also helping to identify individuals at higher risk and personalize treatment strategies. While bladder pheochromocytoma remains a challenging condition, ongoing research and advancements in treatment are continuously improving outcomes.